Well, apparently I'm a lot shorter than Dr. Tobian is. Good afternoon, everybody, and welcome to the afternoon session of Track 1. It's my honor and privilege to introduce Dr. Westhoff today. She's the director of the Immunohematology and Genomics Lab at the New York Blood Center and is an adjunct assistant professor in the Department of Laboratory Medicine, the Division of Transfusion Medicine at the University of Pennsylvania. Dr. Westhoff received her Ph.D. in molecular genetics, studying the evolution of Rh genes, and did postdoctoral work in immunology. As an expert in the Rh blood group system, her clinical focus is on improving matching of patients with blood donors for blood transfusion, especially for patients with chronic anemia, including thalassemia and sickle cell disease, with funding from the Doris Duke Foundation. Dr. Westhoff has served on numerous AABB committees, including the AABB Board of Directors. She serves as reviewer for numerous journals and is associated editor of the blood group genomics section of the journal Transfusion. At the New York Blood Center, she directs the only AABB-accredited molecular testing laboratory for blood groups, has lectured nationally and internationally, and has authored over 75 scientific articles and numerous book chapters. Please join me in welcoming Dr. Connie Westhoff.
Thank you, Vicki. I also am not as tall as Erin is. So I want to thank the organizers for the invitation. Wow, what a great meeting New Jersey always has. I am always impressed by your turnout, and I think every other state envies your support, and it's really a testimony to your leadership and organization. And what a testimonial at lunch. My goodness, over 500 blood products. Do you suppose she was O negative? I wanted to know what type she was, because what we're going to talk about in the next 40 minutes or so is who really needs Rh negative blood and Rh immune globulin. And all I could think of, oh, she was an O negative, you know, when would you be starting the positives, and when would you be trying to decide when she was going to stop bleeding and revert back to her type? And she's a young mom, and so what a dilemma that would pose. So those of you who aren't serologists and maybe are more in the procurement area, I hope this has a few tips for you also. But those of you that are serologists and have seen this firsthand know that sometimes we have difficulty determining what the Rh type of a patient is. And I want to go through today why that is. There's a biological reason why that is. It isn't because we aren't smart or our reagents aren't good, etc. It's the genetics of the individual I'll leave you with. And then talk about what is kind of hot in this industry right now is looking at, well, now that we have molecular genetic methods, how can we do better for these patients and maybe save some products in the process? So I just want to start off with talking a little bit about why is it sometimes problematic to type a patient. And it all starts with the very fact that, number one, there's a variation in strength of the D antigen on some red cells. It's genetics. Okay, so how many people does that involve? We'll talk about that. The other thing is we don't all type the same way. Some of us are using tubes, some of us are using gel, etc. So we end up with discrepancies between various labs or even within the same lab. Thirdly, our reagents now, since the advent of monoclonals, have different clones in them and different formulations. So even if we're using the same method as the laboratory across the street, we may be using a different manufacturer's reagent. So all of these variables come into play. And then the big deal is the interpretation. Some people are saying, okay, I'm going to be conservative and call these people negative. I'm going to be liberal and call them positive. And so the interpretations vary across the country. So I would argue that it really is pretty amazing we don't have more discrepancies than we do. We really do a pretty good job of Rh typing, I think. So the very first problem is that D is not a single change on the red cell membrane, not like, for example, JKA and JKB. It's a single amino acid change, end of story. You have asparagine, you have a JKA, aspartic acid versus asparagine gives you JKA or B. With the RH system, it detects the presence or absence of a whole protein, not just one epitope on a protein. In other words, D antigen then differs from the CE antigens by many multiple amino acid changes. And if you're Rh negative, you don't have this protein. So when you see it, there's a whole lot of differences between your CE and this D gene. And the other problem we have is, early on we thought, well, if the amino acid changes are in the membrane, under the surface of the red cell, the immune system can't see them. So if someone has a genetic change here, well, they're going to type normally and they won't make an antibody. Well, that's not really true because they're not one-dimensional structures. These are very fluid in the red cell membrane. These coils aren't like this. They are very movable. And when you look at the Rh antigen in the membrane, changes, unfortunately, under the surface can disrupt epitopes on the surface. It's like a boat on the ocean. Something, some kind of impediment here can change the D epitope. So generally speaking, if someone has a change in their structure under the membrane, it's not very immunogenic, but we can't say it's never immunogenic. So unfortunately, we've got a lot of changes in D. So I just wanted to review a couple of minutes what your Rh system is all about and why it's more complex than others. At your Rh locus, you actually have two genes. One encodes C and E, and one encodes D. And like I said, there's 32 to 35 amino acid differences. So if you're Rh negative, though, most of us who are Rh negative don't have a D gene. It's been completely deleted. Your red cells are just fine and normal with just having the CE protein. But this finally explains then, if you're Rh negative, you have this protein, you don't have this protein, you see it through transfusion or pregnancy, and you have a lot of different epitopes and a whole lot of response can take place. Now, that's not all that's happening at the Rh locus. These are like siblings. They are duplicated genes. We have lots of duplicated genes in our genome, but these happen to sit very close to each other, back to back, so to speak. And what we now know happens is they still talk to each other. They're like siblings wearing each other's clothes. Part of the CE gene can insert into the D genes. Part of the D gene can insert into CE gene. This is what we call a hybrid allele or a hybrid gene. And these are what cause all of these antigens in the Rh system, because this is all going on in many different populations. So we have cases of D being inserted into CE or CE into D. And so I show that on the next slide with all of these boxes that are meant to represent the 10 coding exons of the D gene and the 10 coding exons of the CE gene, and all of these conversions or exchanges that are taking place between these siblings. So what happens here? These are all of these, a number of the reasons we have what we call partial D. Those of you who aren't familiar with this, we've known for a long time that people who are D positive can make anti-D, and this is the reason. They have parts of their gene replaced with parts of their CE gene. This makes new antigens on those cells, and it makes them able to respond to the piece that they're missing. So what happens in the transfusion service? If you're a female under the age of 50, childbearing potential, and have one of these partial D genes, you should be receiving Rh negative blood, and you should be getting Rh immune globulin. The problem is we can't detect them serologically. And I especially want to focus on a partial D called D6. These are several different flavors of D6. But D6 has been an important partial D because our reagents right now are all designed around not detecting partial D6 in the initial spin if you're doing a tube test, or in the gel card if you're doing a gel card test. Because these women really do need to be Rh negative, because the only cases of fatal HDN in an Rh positive woman with anti-D are in these women with D6. Now, women with D3A or D4A, et cetera, also make anti-D, but there have been no fatal cases. They've all been treatable and have all been able to have positive DATs and survive. So this is the bad one, the outlier. It's the most prevalent in Caucasians, and we'll talk a little bit more about that. So let's summarize how much variation there really is out there. Now that we have genetics, there are over 200 different D alleles. That means 200 different flavors of the gene circulating in populations. These encode amino acid changes in the protein. So really, we could potentially have over 200 different subgroups of D. We don't, thank goodness, but we are realizing that there are certain ones that are more likely to be immunized than others. Now, there's two categories that we've kept in mind in the blood bank, and if you haven't seen these before, I'll try to briefly summarize them. We've kept this terminology because it's helpful clinically. We call people weak D if they have changes in expression levels only and aren't particularly immunogenic. And the definition of weak D has always been that it reacts weaker than expected. And that definition for ABB is less than 2 plus or equal in a tube test. Now, that's not necessarily the case in a gel card, et cetera. I'm going to make the point that you all should define in your own laboratories what is weaker than expected in your hands with your reagents and your techs. But what we know is now that we know genetics, weak D type 1s, 2, and 3, those genetic alleles that we call weak D types 1, 2, and 3 are the most common, and they're not at risk for anti-D. There are some weak Ds like 15, 18, et cetera, who have made some anti-D, but they've been weak. They've never been associated with HDN. But at this point, we're going to say weak D types 1, 2, and 3, the community agrees that they're not at risk, and since they're not at risk, we'd like to know about them and save the Rh negative blood and Rh immune globulin. Whereas the partial Ds, they are at risk for clinically significant anti-D. Boy, that is very sensitive. The problem is we can't distinguish these by our serologic typing. What's the problem here? Partial Ds oftentimes can react 2 plus also. So is it a partial D or is it a weak D? Because it reacts weaker than expected. We can only tell genetically. Okay, so how many patients are you really going to see in your practice? It depends upon your ethnic group. About 25% of the CAP survey folks in 2014 had seen at least one patient in the past 12 months with a serologic weak D who made anti-D. And this is in this report in laboratory medicine. If you look through the literature, you can find about 30 reports of D-positive people who made anti-D associated with some hemolytic disease, either anemia or severity. They were never genotyped, but we presume those are the partial Ds. But when we try and look across the literature and see different populations, we come in with a range of about 0.5 to 4%, depending upon the ethnic group, that have only an altered D gene. Now remember, you can either be deleted on one of your locus, so you can be heterozygous, or you can have 2 D genes. And so in our sickle cell patients, at least 40% of those kids were carrying at least one partial D or altered D allele. But remember, only 4% by the time you have to be homozygous for altered alleles or hemizygous. It really depends upon the ethnic group, but partial Ds are much more prevalent in African American sickle patients. But anyway, it'll depend upon your population and who you're seeing. So then I'd like to talk a little bit about the different ways we're doing typing and what our reagents are meant to detect. One of the reasons people say we have discrepancies is because we type donors one way and patients another way. But there's reasons to do that. But most of you are using either a manual tube, a gel card, or a solid phase. But in donor centers, most places are using the PK instrument. And there's many different levels of automation. So again, just driving home the point, there's lots of ways to do D-typing, and there's lots of different instruments and lots of different methods. So ABB, because our goal is to prevent any anti-D, if possible, being transfused to a D-negative person, requires that a method designed to detect weak expression of D when you're typing at the donor center needs to be employed. And now that's not to be confused with retyping. When you retype at the hospital, you're not doing a weak D test. Only the donor center is required to do a weak D test. And in the US, on the PK, that's done by enzyme treating the cells and actually using 2 different anti-D reagents. Or some donor centers use an IAT. But we know that this isn't perfect. Some donors are missed. In a study we did with the Red Cross, a weak D type 15 is often missed. It's a very low level of D antigen. We know D typing's not perfect. FDA knows it's not perfect. So if a donor stimulates anti-D in a patient, you should always let your donor center know and report that back. But today we're not dealing with donors and the problem of donor typing. No one wants to talk about screening our O-negative donors more stringently and maybe losing some of those important donors. But in the study that I published with the Red Cross, we actually showed that actually it saved donors because there's false positives actually coming through the PK also. So, you know, we would save as many as we lost. But like I said, I'm not here to talk about donors today, and I'm talking about patients. So on patients, the goal is to prevent any anti-D, of course. So testing for weak D expression is not required. They're actually changing the word from required to optional in the new standards. I'm not quite sure what that means, I guess. But anyway, so most of us certainly aren't doing a IAT test on women or patients. Of course, there's an exception. When you're evaluating a mother for Rh immune globulin, you are required on a newborn to do some kind of test for weak D. So there's been some criticism. Why? Maybe we're making this problem of D discrepancies, person typing one way, one place, and another place because we're doing different typing for donors versus patients. But there's a reason why we started doing this way back in the 80s, because some partial D are only detected in the indirect antiglobulin test. In fact, I'm going to show you that that's what the FDA wanted when we designed our monoclonal reagents. Females and OBs were thought to be better served as Rh negative if you're partial D, and FDA requires that the D6 only be detected in the indirect antiglobulin test. And so they had intended, but they hadn't communicated very well, I don't think, to all of us out there typing OBs and typing female patients that we not do an IAT so that these D6 women get treated as Rh negative. But a lot of us dropped the IAT because we were concerned about false positive, if the patient had a positive DAT, et cetera, or RULO. We didn't want, you know, techs calling people positive when they were really negative and had a positive DAT. So in the CAP survey, the majority of hospitals do not do an indirect antiglobulin test for serologic weak D for patients. Some still do, but the majority do not. So like I said, there's been some criticism. Why was there ever a reason to type someone different if they were a donor versus a patient? And again, I would make the point, it's always been recognized that donors, you really want a sensitive test, and the patient, there was no harm in treating the patient as Rh negative, no harm. So I'm going to try and make the point today that we're probably using, if we're being very conservative in treating these people as Rh negative, and I just came from Ann Arbor in the Michigan's meeting, where John Judd had set up years ago that anybody who was a 3+ got called negative. And so they're using a lot of Rh negative blood to avoid sensitizing any women with partial D. And so I was there to help them revamp and rethink that approach. Anyway, I'm going to try and convince you today that we have now methods that we can reduce the amount of Rh negative blood we're using. And if you go back to Peter Isset's days, the forefather of Rh, in the 60s and 70s, when they were using polyclonal reagents, Peter Isset said, you really, in traditional blood bank, it demands that before a donor can be regarded as Rh negative, he not only has to lack D, but he has to lack big C and big E. And it was based on science. It was based on the fact that they knew, even at that time, that if somebody's big C positive and appears to be Rh negative, or is big E positive and appears to be Rh negative, they're much more likely to be a weak D. Okay, they're much more likely to be a weak D. And so anti-CDE reagent was actually used to type all donors at that time. And then we had monoclonals, and that's when things all changed in the 80s. And I am one of these people that has been around long enough to remember the 70s and 80s, unlike most of you in this room, I'm sure. These were more sensitive. Many of the red cells that were positive in the indirect were now reactive initial spin. And you could actually select clones for specific epitopes. And so there was a lot of debate in the 80s. Okay, let's select some clones for patients, different clones for donors. What were they going to be? Who was going to determine that? And it was all determined to be way too confusing for the industry. And the FDA said one reagent, but the reagents for the US market have to be non-reactive with D6 on initial testing so that these patients' type is Rh negative. But that clone must react with D6 at the IAT, so donors are typed as Rh positive. And so that is the rule that has driven all of the qualification of anti-D reagents in the US up until the last year or two. So here are reagents that are licensed in the US, and I'm just using this to point out, yes, you can see a lot of the clones are all different. The majority are different. But even if they've got the same clone in them, the Series 4 and the Series 5, they have different formulations and different potentiators, so the same cells can react differently with the IgG component with the same clone. So these often differ in reactivity with red cells with a partial or weak D. Like I said, even the same clone can react differently. And we find that red cells with, say, a certain weak D or a partial weak D, depends upon the C or E status of the red cells, how they react. But all these reagents then, with the exception of one, follow the FDA rule. Can't react with D6 on initial spin, must react with D6 in the IAT. And Alba has been recently able to bring this Delta clone on the market. It detects partial D6 at initial spin. So in the cautions you'll see, this is not recommended for patient testing for transfusion. This is not meant for that testing. But again, it's kind of buried in there, and I don't think it's all that clear. So what's a person to do? Not only are the reagents different, if you look at the manufacturer's instructions to say, okay, according to this manufacturer, what's a weak D and what isn't a weak D, etc. Some say 2+, some say less than 1+. You need to use an alternative reagent. Some warn that patients should not be classified as D positive on the basis of a weak reaction with a single anti-D. If a clear positive not obtained, it's safer to classify the patient as a D negative. And like I said, if you go through every manufacturer's cautions, they're all over the place. And so I think most of the industry is left scratching their head about what is it, you know. So I don't think we get much guidance from our manufacturers. manufactures inserts. And on top of that, because we don't get much guidance, I think, the CAP survey really shows that. The 2014 CAP survey of over 3,000 labs said, when you see this, what do you call the patient? 47% said, well, I call that patient positive, and 11% said, oh, I call that patient negative. But quite a few said, oh, it depends upon if it's a woman or not. If it's a woman, I call her negative. Well, there's some logic there. If it's a male, I call him positive. And again, a lot of people don't have the option of calling even a weak D in their computer system, and so I know there are all kinds of challenges out there. But of course, if you're going to call them positive, you're going to not give a woman RhoGAM, and you're going to give her Rh positive blood. And what you accept then is the risk that she could be a partial, and that you are putting her at risk for anti-D. But on the other side of the coin, if you call her negative, you're being really conservative. You want to make sure she doesn't get sensitized, and you avoid the HDN. But what are we doing? We're using what we feel is a lot of Rh negative blood and a lot of Rh immune globulin that could be saved. And if you're the doctor, if you have the same experience we do, the physician just wants to know, do I give it or don't I give it? I don't know what you're talking about. Just tell me what to do, right? Yeah, exactly. And so what do you tell them what to do? Now that we have genotyping, and I don't mean to sound as an advertisement for genotyping, because everyone knows I believe in it, and it's something I think the profession will embrace, but I think it really helps us here. So now we can detect a weak D at the genetic level. We've got 76 different ways to be weak D flavors, and we're still discovering them. So there's just a lot of ways to be a weak D. But the main point is 1, 2, and 3, which are the most common in Caucasian. 75% of weak Ds are 1, 2, or 3, and we now have enough experience to know they're not at risk for anti-D. And then the partial Ds, we can tell them there's over 100 flavors of partial D out there. They lack epitopes, and they are at risk. One little rule is weak Ds we most often see in Caucasians. The partial D are more common in African Americans. But I think you would agree with me, we never want to diagnose a patient or make a decision based on what we think their ethnic background is, or make that assumption. So what I'm going to talk about is genotyping not based on an ethnic group particularly. So around the work group, around the time of the CAP survey, it was realized that maybe Jerry Sandler, who spearheaded this effort, said, let's get some people together from ACOG, ABB, CAP, the Red Cross, and ABC, and kind of talk about maybe what we could do about this problem with Rh typing. And this work group was charged to come up with some kind of recommendation to maybe use genotyping when D-typing discrepancies occur, when there's a serologic weak D identified. And the goal isn't to push this on the industry. The goal is to start phasing in, getting people to think about using this, and what benefit would this have. Any recommendation from this group should clarify the issues with typing a little bit, and helping to avoid the unnecessary use of Rh immune globulin and the transfusion of Rh negative cells. And one of the charges was to look at how much excess Rh immune globulin are we actually using. And I'll just share the New York Blood Center experience with Rh negative blood. And I don't know if you've seen the same, I'm sure you probably have. As the overall blood usage continues to decline dramatically, our Rh negative usage is increasing. You know, we need more and more Rh negative blood. We're up near 10% now to fill customers' needs and wants. what's driving all of that use of Rh negative. Is it all just traumas? Is it all the neonatal intensive care? Maybe some of it is, conservative practice, giving negative blood when a patient could be positive. We think in our community, some of it is giving it to African American sickle patients. You want a CE Cal negative unit to go to them. We assume, people who are realizing that that's in the negative blood supply also. So we're trying to educate folks there. Over the last few years, I've been working with Rich Haspel here at the Brigham, and they had started genotyping any OB women that had a D-typing discrepancy. That meant she was positive previously and now she was typing negative, or the reverse. Or the physician's office said, oh, we have her as negative and you're getting her positive, or the other way around. And you've all seen these, right? Or if the typing was weaker than they expected in their hands in their lab. And when we total up the last 2 years' experience, from genotyping these women, 75% of them were not candidates for Rh immune globulin, and 25% were either new folks or potentially at risk. So they feel this was worthwhile and able to use this to guide their recommendations for their physicians. So they manage their patient according to the genotype. So the work group did come out with some recommendations, and this is a rather busy slide from that publication, and I'll share the publication with you also at the end. Look down the center. We tried to make it a very simple, straightforward recommendation that certainly if they're negative or clearly positive, you do what you're doing today. But if you see a discrepancy or an inconclusive result, or the strength of the reaction isn't what you expect in your hands, in your labs, to send it for genotyping. And if it's a weak D, type 1, 2, or 3, that person is not a candidate for Rh immune globulin and not at risk for anti-D and can get positive blood. And if they're if they're not a 1, 2, or 3, then they may be at risk, and so treat them conservatively. So this is our first step to begin to phase in looking at solving this problem. And one of the big questions was how much benefit would this be really? How much Rh immune globulin are we using unnecessarily? And this was a real effort to use the current number of live births, the number of pregnancies, the number of those expected to be thought to be Rh negative that were really serologically weak D, how many of those would be type 1, 2, and 3, and about 25,000 unnecessary antepartum and postpartum Rh immune globulin injections are being used, probably. Now, we've had women come to us directly and find us on the internet and say, I'm supposed to get this shot. They said there was something funny about my D-typing, and I don't know that I really want that shot because it's a human blood product, and can you type, would you genotype? And like I said, women are becoming very savvy and knowledgeable and finding alternatives. So it is something that's out there. But you might say, well, why would I be concerned about excessive Rh immune globulin? It's one of the greatest medical advances, and it's very, very, very safe. And it is very, very safe. But I would argue it's a human blood product. We all know that. It's manufactured from paid donors. We all know that. The women who used to have high titer anti-D are not making anti-D. We're protecting them. And so these have to be immunized donors and paid. And there's some ethical issues when biological products are administered unnecessarily. I can't imagine if we get a new emerging threat like HIV into the supply and happen to be an Rh immune globulin, how we would explain really giving unnecessary product. And though there are no reports of anything like hepatitis, it has occurred in other countries where Rh mutant globulin was a batch was not properly treated, and hepatitis did result. So again, I think the ethical issue when giving something unnecessarily is the issue here. Now, if we look at Rh negative units, would we save much here? Can we guesstimate how much we'd save? If we look at the number of transfusions and the number of negatives and the number that we'd anticipate to be weak Ds, and what would we come up with? About 50,000 additional Rh negative units in the U.S. for proper use for other situations. So not small, not mammoth, but I think would have some impact. The other thing that the work group kind of wanted to do was this confusion about what is a weak D. And again, I really want to focus on the fact that we use the ABB definition that is about with a tube test. It may be different in gel, etc. It depends upon your population, and that you should have a policy and that you should determine what it is in your hands. The other important thing is we're not suggesting, our dear leader, Dr. Sandler, really felt that people should go back to doing IATs so that we really know who all of these people are. But that really wouldn't be economically feasible for any of us, etc. So we realize that this isn't perfect. It isn't going to catch them all. So we're not saying you got to change policy or change what you're doing now. Just be aware that you can use Rh genotyping to resolve these D-typing discrepancies, and you can use it to manage clinical decisions, and so that's why it really focuses on OBs and women of childbearing age, and also on the blood supply. Now, we said anyone that's a weak D other than a weak D type 1, 2, or 3, we just don't have enough experience with or enough cases to follow. So we're going to stick with recommending regular prophylaxis at this time. But there are a few reference laboratories doing this test, and we want to say, give us an affordable first-tier test so that if I just want to know is it 1, 2, or 3, I don't have to spend a whole lot of money. Yes, if I want to know exactly what it is, maybe, but give first-tier testing so that the clinical relevant genotypes can be detected. And then get clinicians and investigators to be aware and publish outcomes of pregnancies and transfusions for other genotypes. And we really felt that phasing this in and starting to apply modern genomic methods, which are being applied in every area of the laboratory, as you already know, that this is one area that would really benefit transfusion and give you a more precise decision for that OB women. Now, what is the state of genotyping? We know that people don't all do this in their lab, and they shouldn't be doing it in their lab. It won't be cost effective. Right now, it's a laboratory developed test, so even if it's manufactured as a kit, it's considered an LDT and licensed as an LDT. It's not an FDA licensed kit. I personally don't think D genotyping is going to get an FDA license. If there's over 200 different alleles, 76 ways to be weak D, you almost have to do a gene sequence to actually make sure that there's no mutation in that D gene. And so I don't see that as a licensed test for the industry in the short term. But these research use only testing are being used by all hematologists and our colleagues, and they're performed in a clear regulatory lab, validated testing, so they're high degree of accuracy. So I don't think we should frown on something that's not FDA licensed for labeling a blood product. This is a clinical test. Many people say, well, you're using DNA, so don't I have to get an okay to do it? Is it a genetic test then? All states to date have determined that it's not genetic testing for disease. It's a rather Rh typing by another method. But again, Rh typing, genotyping is usually done on the order of, or the pathologist or some kind of physician is involved in that. There is a CPT code for it. And what I would say about the cost of testing, it's not stabilized yet in the industry. So if it's not stabilized, one of the important questions to answer, and with the help of Aaron, who I think is still here, who you heard speak this morning, we looked at the cost-benefit analysis for this. Is there a cost-benefit reason to do this? So the goal of Aaron's evaluation, with help from members of the work group, was to evaluate the cost for genotyping and in pregnant females with a weak D phenotype. So we wanted the answer to where do we have to tell manufacturers that this test needs to come in at this amount to be cost effective and to be implemented. So the strategy was to compare it to managing women very conservatively as negative, assuming it gets done at the first pregnancy, when her RH typing is usually done, so that you have the results by the time she needs antepartum and postpartum, and that becomes part of the medical record. And I know there's some hurdles here also. Electronic medical record is important. And if you're the one ordering the test, and it's no good to just stay in your laboratory, it's got to get back to the doctor's office, and it's got to be made part of a record. All these things are happening, I think, over the next few years. And then the analysis also looked at direct medical costs over a 10 or 20-year period for a population of U.S. women, a very diverse population, et cetera. So we're looking here not at the cost of just the woman's pregnancy, because if a woman has 2.2 children, then you know she's going to get 2 antepartums and 2 postpartums, and you start adding that up, then you know how much the test should cost. But this analysis is spread over the whole healthcare system. That's the way you look at costs in a health cost-benefit analysis. It's for the whole system, not the individual's insurance company, et cetera. So these are the costs that were used in the analysis. Led by Aaron, our colleagues at the Red Cross, et cetera. These are the CMS reimbursement codes. You could always argue that CMS reimbursement rates are below our actual cost, but Aaron would, I think, support the fact that at least this gives a standard cost that you can use across the country, et cetera, as a comparison. And so here's RH immune globulin in this range, the administration costs in this range, and the genotyping costs in this range. So the bottom line, and this is early view from Transfusion. It's I should be published soon, I think. The cost savings over treating as RH negative means the test has to come in around $256 to be a cost savings. So there we have the cost of testing. Now, the group addressed this approach for OBs. We didn't say anything about using this to detect partial D phenotypes. And we know a number of partial D types strongly D positive, and we're not going to detect them. So we know this isn't perfect, but we weren't ready to deal with that. First of all, some women with weak D won't be detected. So you just type them as negative. You don't know they're, especially weak D type 2, they're really difficult to detect except IAT. They may get unnecessary ROGAM. So how could we correct for that? It'll require testing of all Rh negative women at some point in the future by Rh genotyping. And the same with the women with partial D who type strongly D positive. And in our African American population, that's D3s and D4As, and they type nice and strongly positive. We don't know about anti-D till they make it. We don't have any cases in these women associated with fatal HDN, thank goodness, but they do have costly monitoring of their pregnancy because you're titering them all the time, et cetera. So ideally, again, we'd want to detect those. So we realize that our recommendations don't deal with this, that to catch all of these would mean testing all negative and all positive women by Rh genotyping. So everybody, as you come into your OB, would get an Rh genotype. And I think that will be our future. I really think the Rh status will be determined by genotyping as the costs come down. And my daughter was recently pregnant, and she was offered all kinds of genetic tests during her pregnancy. And if she'd had a D type that was, you know, uncertain, I'm sure she would have agreed to a $260 genotyping test. And I do think mothers will want to do this so they don't get unnecessary Rh immune globulin. And so, in summary, and I'm happy to take your questions, if you encounter an Rh typing discrepancy or it's weaker than expected, do consider referring for Rh genotyping, especially if it's a female or someone needing long-term, not only just women, but if you're going to have someone on long-term transfusion support and there's a potential to keep them on positive units instead of negative, think about Rh genotyping. Make sure it gets to be part of the office medical records. And this is only one-time testing, okay? So nobody's talking about repeating this every time a patient comes in, et cetera. So I'm just sharing with you the recent publications and the discussion around this topic. This is the commentary that came out from the work group. And again, the goal is to begin to standardize practice by having folks use Rh genotyping in these situations. This is the evidence from the Haspel group about how this works for their situation in their hospital. And then again, the study that Aaron led to rather than manage them as Rh negative, here's the cost associated as an early view publication. So with that, I'd like to thank you for your attention and welcome your comments. Yes. What method of genotyping? 3 simple RFLPs. And then if it's not weak type 1, 2, or 3, we used others, yes. So it's a mix of a bead chip. We also use the platform that is Luminex, so we've used them all. So not specifically one. And Immucor did ask me to please let you know that they are taking donations of your buccal swab, meaning they will do a buccal swab, and they won't do your D typing. They don't do that, but they will do your HEA typing, your full genotype at their booth, or send you the results, I'm sure. If you're interested, they must not be getting many takers that they asked me to. But if you want to know your blood group profile, that they will do it. So thank you again for your attention.